Thank you very much, Dr. Butler.
Well, thank you very much. I really, really appreciate the opportunity and the honor to be with you here today. So one, thank you, Lisa, very much for that very kind introduction. One problem with a kind introduction is that you are sort of set up to fail because it can only go downhill from here. So adjusting for that, when Peter invited me, I was sort of absolutely delighted to come here. And I was going to give a heart failure talk, sort of, heart failure and trials and data and all that kind of stuff. And then about a week ago or so, I wrote to Peter and Lisa and I said, well, I mean, maybe it's a general cardiology crowd and too much sort of details about heart failure may not be of interest. Do you mind if I just sort of change the topic and maybe talk a little bit about general cardiology? So I was going to pivot and go for a different talk. And then last night we went for dinner. And the conversation in the dinner sort of went in all different directions. So last night I completely changed the talk again. So I'll do a little bit of an experiment with you today, and then let's see sort of how this goes. Okay, oops, wrong one. Okay. So first, quickly, my disclosures. So I'm working on a lot of drug and device development programs, but none of them are directly relevant to my presentation because I'm not going to talk about any drug or device or disease. My talks will be focused on sort of healthcare systems, and it will be a little bit U.S. focused. So the disease states, I think U.S. and Canada, there's a lot of overlap, but some of the details about the healthcare system may be different. So you'll just have to sort of adjust for that a little bit. And that a lot of what I'll be talking about are my opinions, so I could be completely wrong as well. So these are my disclosures. So let's sort of think about what the American body looks like in 2024. So this is data from the AHA statistics. 2022, 2023 data came out, and basically there's no difference as you might expect. So right now, about 20% of adolescents are obese, not overweight, are obese in the United States, and about 40% of the adults are obese. If you now put obesity and overweight together, we're talking about 3/4 of the population. 3/4 of the population are overweight. So this is now the norm in the population. I mean, you can imagine, like, how you draw the normal distribution of lab values and you say, well, the 97.5% is the normal. I mean, we are at a point that, technically speaking, if today we were to draw the BMI, normal would be, I don't know, like 29 or something like that. So that's where we are in terms of the obesity epidemic. Cholesterol. So a bunch of people, statins are very cheap. Statins are available for a very long time. But when we measure cholesterol, about half the population is like walking around without cholesterol control, and we don't even know how many people who needs to get their cholesterol checked that we don't check. Hypertension is obviously almost ubiquitous as you grow older, at least in the U.S. population. By the time you're a octogenarian, it's almost 90%. But again, many people don't know that they have hypertension. It's a silent disease. Those people who have hypertension, we don't treat. And when we treat, we don't get to control. So control of blood pressure. So all the three steps, you have been screened, diagnosed, treated, and treated to control is about 20% or so, about 80% of the time. We are not reaching those targets. I will get this eventually, but here we go. Okay. Diabetes, prediabetes. So about 15% or so folks now have diabetes. The control is exactly the same as hypertension. About 20% of the patients with diabetes are actually at their target goals. And then if you look at pre-diabetes at the bottom, that's another 40%. So another 40% of the population is just waiting to develop diabetes. And if you put together, more than 50% of the people have diabetes. What about chronic kidney disease? So a good 35% or so have some reduction in eGFR, and USER is difficult to assess at a population level, but in NHANES, whatever the best assessment you can get, we're talking about a good another 10% of the folks that are spilling some degree of protein in the urine. So if you look at the total sort of the cardiovascular burden, whether it's lipids, diabetes, hypertension, CKD, obesity, all of them are highly prevalent. We don't seem to be able to screen for them. We don't seem to be able to treat them. We don't seem to be able to control the epidemiology and all the things that are going up. So has that taken a toll? How are we doing overall as a society? So it may be hyperbole. I don't know whether what I'm about to say is true or not, but this is at least what I've heard some pretty educated people say, that the current Gen Z generation in US is the first generation where the life expectancy of the children generation is going to be less than their parents' generation. This has never occurred in the US before. So for the past 100 years, every decade, the life expectancy in US has increased till about 2010, and it has started now reversing, and the gains are lost. So this is 2010 onwards, and this is we're talking about cardiovascular mortality. So this is not a drug epidemic, opioids and stuff like that. This is not COVID. This is cardiovascular mortality. These data are a little bit dated. There's a recent paper that I reviewed. It hasn't been published yet. And if you extend it to 2024, the trend is continuing to go up. So common diseases, population-based mortality is going up. And then epidemiology, I just sort of put the heart failure slide. And the heart failure prevalence is also sort of increasing at a population level. So you have these common diseases. The common diseases are taking the toll. The epidemiology is worsening. And all of these things would be sort of okay to tolerate if you had no sort of therapy that you can give to the patient, and that's obviously not the case. So I'll just make a few heart failure comments, but I mean, you can make the same comments for diabetes or obesity or for anything. We have incredibly effective therapies available for these patients. So if you look at the quadruple therapy, RAS inhibitor, beta blocker, MRA, and an SGLT2 inhibitor, we're talking about extending the life. I mean, the NNT is almost 4. There's a 25% relative risk reduction if you treat the patients for 2 years to decrease one mortality event. And then if you just focus on the Kaplan-Meier curve, the red line is not no therapy. The red line is what happens when you give ACE inhibitor and beta blocker. So you can imagine if somebody was on no therapy, how bad the prognosis would be for patients with heart failure on ACE inhibitor and beta blocker. But if you switch ACE inhibitor and beta blocker to ARNI, beta blocker, MRN, and SGLT2 inhibitor, you can see the prognosis getting substantially better. And on average, you're increasing survival by 6 years. On average, by 6 years, if you're somebody in your mid-50s or early 60s. Even if you're an octogenarian, you're talking about increasing life by over a year. So substantial benefit. So common diseases, increasing in prevalence, big healthcare cost, effective therapies are available that can simply change the trajectory of the disease. So I'm sure we're all jumping up and down and we're just taking care of all the problem. Not so much. So CHAMP registry, I only give you the example of the CHAMP registry. There are more recent data as well. So these are the data from the triple therapy regimen. So this is before SGLT2 inhibitors came on board. So this is RAS inhibitor, beta blocker, MRA. So if you give the data to clinicians, obviously one of the first things you hear are that my patients are not necessarily represented in this, that not everything is in the medical record. How do you know with cross-sectional that things are not on the change and that things will change over time, and all those kind of things we sort of listen. So when we did this CHAMP registry, we sort of try to build in all of these things in the data abstraction sheet. So one, this was not only data collection, but this was followed by site interviews as well. And in the site interviews, so first of all, we were convinced that whatever data that we will find in terms of how we are treating chronic diseases, and on this one, we are focusing on heart failure, whatever we are doing, we will be significantly overestimating the treatment for 2 reasons. One is that we are going to centers that are interested in heart failure registry. This is significant subselection of the population. They have come forward to do this registry. That's one reason for selection bias. And the second reason for selection bias is that we told them that we will be following up and we will see what changes occur over time. So there are two, and that you will be compared across various different sites as well. So about 150 sites in the US, 3,500 patients, primary practice, primary care, cardiology, academic, private, all sorts of mixture as well. But the one thing we did is that there was one field in the case report form, and that's the most critical thing to understand. And we said that we can 100% disagree with your logic. But if you say that this is the reason why I did not give this therapy, we will accept your reason. So suppose you say, person has a blood pressure of 110, I'm concerned. Somebody has a creatinine of 1.6, I'm concerned. I'm not going to give the therapy. We'll give you the credit because of trying to get to this bottom line of what is the true denominator, because otherwise people say, well, not everything is documented in the medical record and I don't know. So we won't ask you a question. So we just want to get to the pure denominator. And this was the result. Triple therapy was given in about 25% of the patients. 75% of the patients were 1 or 2 drug therapies. They were not. And then you ask the question, and they're just basically saying the patient is doing okay, and we'll sort of wait and see how the patient goes. We don't want to get the patient back to get blood tests, and all that. And remember, there is no cost issue here because ACE inhibitor, beta blocker, and MRA are all generic. You did not need to give ARNI, and there was no such thing as SGLT2 inhibitor. So these are generic triple therapy. Cost is not an issue. You're given all the credit for which you are saying I'm not giving, and yet 75% of the patients were not on triple therapy. And if you tie that to my earlier slides of where we are with comorbidity burden, effective therapies are available, and sort of nobody is using these therapies. And, I am talking about heart failure because I'm a heart failure doctor, but I mean, we can say the same things for lipid, hypertension, diabetes, CKD. We can correct it today. So let's just think about how are the guidelines written. First, medicine is an incredibly conservative discipline, right? So we are sort of stuck with this p-value of 0.05. That means we need sort of 95% certainty, and it's only 95. Not only 95% certainty, we need 95% certainty on thousands of patients worth of clinical trial. I don't know how Canadians make their decision, at least in the US. If you go to the government and you're trying to sort of figure out, you have, one pile of money, and whether you're going to make bridges or open schools or, do whatever, dig a river or whatever, their p-value for the economists, for the government, is about 0.3. In other words, if you are 70% certain, let's go ahead and do it. So one, we are a very conservative institution. So now you do thousands of patients worth of trial, then you get a p-value, and not only one, you get the p-value of less than 0.05 in multiple trials. So you go from one conservative to the next level of conservatism, which is the regulatory bodies, right? So the FDA will be very careful without approving a drug and bringing it to the market. And then from there on, it goes to the third layer of conservatism, which is the Professional Society Guideline Writing Committee, whose job is to criticize. Like, no matter how good a trial you do, their job is to just criticize, right? So by the time something becomes a class 1 recommendation, gosh, it has gone through so many layers. And now we live in an electronic health record era where, at least from my hospitals, I can map out everybody who does not have controlled lipid and controlled diabetes and control this right on my laptop, desktop, for all 52 hospitals. I mean, this is all within our reach, and nothing happens. And again, this is a global issue, but more so in US. Like, the healthcare cost is such a big issue. So this is something that the US government wants to do to treat people well and decrease the cost. The NIH is behind this, the FDA, the CDC, the ACC, the AHA, the professional societies, and the doctors and the nurses, and everybody wants to do it. And we pay a lot of money for it, and nothing gets done, right? And I showed you the data where we are with chronic disease management. So the question is, how can that be possible? Like, how is it that this is where we are? So from here on, I'm going to say a bunch of things that I will completely lose all credibility with the audience, but hopefully towards the end of my presentation, I'll make up some of the credibility. So let's take a step back and sort of think about what are human beings sort of capable of aspiring to do, and what are we capable of doing? So let's sort of start with sort of what are we aspiring to do. So there are theoretical physicists who are sort of, from the Einstein days up to now, the whole field continues to move about the space-time reconstruction and how we can sort of go back to actually figure out our own source code, right? So where is the human beings coming from? What is this sort of this whole game, whether we're in the simulation or not? And there is, I mean, this is not sort of philosophical mumbo jumbo. There are like mathematical models being driven to sort of go back. Okay, so this is all theoretical. Believe it or not, I am not making this up. You can Google this. So there's a lot of interest by a certain sector about intergalactic living, right? So Elon Musk, colonize Mars, all that kind of stuff. So you have to think through a lot of things if you're going to live in multiple planets. So one of the things is where is the food going to come from, right? So we need to have enough food sources to be able to do so. So one of the experiment which is right now being done, I have no idea whether this thing will work or not. Sounds to me pretty cuckoo that it's not going to work, but nevertheless, people are working on this, and that is to develop chlorohuman, and that is develop chlorophyll in human skin that we can develop ATPs by light, and we don't have to eat. So there are experiments going on developing chlorohumans that we will at least partial energy requirement will come from light interacting with our skin, just like the leaves and the plants develop sustenance. Okay, let me come a little bit down to earth, only a little bit, not totally. We are mining asteroids today. This is not sci-fi. Up until now was all sci-fi. We are mining asteroids. So again, human beings want to do it. We are like sending these things and we are mining minerals and whatnot from the asteroids today. Okay, let me go down and talk a little bit medicine. So I had no clue up until 2 years ago. And when I took this new job, it turns out that my medical center is the #1 in the country for uterine transplant. And there's a whole series of live births that have been given after uterine transplants. I mean, just imagine, let's just take a step back at the awe of what we are doing in medicine, a uterine transplant with live birth. All the things that are going on with CRISPR technology, gene editing, and cell modulation, immune therapy, CAR T cells, completely revolutionizing the medicine. So if we want to do things, we can do some really, really big thing. As a friend of mine sort of always said, how is it possible that a man can go to moon but cannot give 5 milligrams of lisinopril? Like, what exactly is going on here? So the question is sort of what drives human behavior? And there is this sort of a framework or COMBI, which is capability, opportunity, and motivation drives sort of human behavior. So all of these examples I have given, whether the chlorohuman becomes successful in the next 50 years or not, whether the asteroid mining becomes standard, whatever happens with CRISPR therapy, gene therapy, whenever somebody thought about this, whenever somebody was thinking about CRISPR for the first time, which is now a reality, it's a reality that we live in, they have absolutely no capability of doing it. And they had absolutely no opportunity to do that. They only had one thing, and that is that they were motivated to do it. And when it comes to chronic diseases like hypertension, diabetes, CKD, heart failure, whatever, we have all the capabilities to do it. We have all the opportunities to do it, but we seem to have absolutely no motivation to do it at all. No motivation to do it at all. And we can go and we can have a long discussion and everybody will come up with the same reasons. I'm busy, I'm seeing too many patients, there are not enough time, the drug costs too much, there are no incentives, all that kind of stuff. At least you guys don't have to deal with something called prior authorization, I assume in Canada. There's no such thing, right? Okay. You don't want to know. Okay. So the issue is, and these are all genuine reasons. I mean, we have 15 minutes in the clinic. The clinics are packed. A bunch of things are sort of happening. But the question in the middle is sort of what are we achieving with the ecosystem in the healthcare that we have created if the Canadian system for chronic comorbidities is even remotely sort of looks like what it is in the US, and I assume there'll be a lot of a sort of overlap as well. So there are sort of several different things about this. I don't know whether sort of this whole concept of Moloch and the sacrifice that you give to the deities, and in the sort of the business sense or the philosophical sense, what it means is that people give a lot of sacrifice for sort of the beautiful city that you have created. The problem is that the sacrifice that you give, which is the incentive structures that you have created for the beautiful city that you have created, at some point, if you don't stop, then you completely miss the point of what you're trying to do. So I'll give you sort of an example. If I was sort of driving from, I don't know, Toronto to Ottawa, and the highway is this long, and I start at 10 miles per hour and 20 and 30 and 40, and I'm driving faster and faster to get to Ottawa, at some point when I get to Ottawa, I got to stop. Because if I keep with the same velocity and same acceleration, I'll pass Ottawa and I'll just keep driving and I'll keep going further and further away from what I'm trying to achieve. And I think that's what's happening in the healthcare, that there may be an era in the 80s or whatever where not enough patients were seeing, and there was not enough sort of accountability, and people were not as careful about finances and whatnot. So all of these structures that have been created for quality metrics and outcomes and efficiency in healthcare, and then our views and the number of patients you see, and the do you this, that, the other, all of that was really good. But I think we have come to a point where we are not sort of taking a little bit of a step back. And it's, again, I don't know how much of this is relevant to US, but I mean, to Canada, but in US, in cardiology, it has all morphed into innovation on the procedural and the device side, because that's sort of the beautiful city. That's the beautiful city which is feeding. And the sacrifice is what we're doing for the chronic diseases, right? Nobody's managing chronic diseases, and we are sort of, in a way, feeding that sort of beautiful city. So we seem to be in sort of a little bit of a Nash equilibrium. I don't know whether the concept of Nash equilibrium is known to some of you, but there's this thing about sort of the game theory optimization where you're getting something out of it and I'm getting something out of it. And if I try to get more from you, the chances are that you will try to get more from me, and we both might lose. So it's best interest for us to just optimize and just stop there and not change anything. And again, at least what's happening in the US healthcare system is that between the large insurance companies, the drug and the device companies, and the large healthcare system, the private large healthcare system, it is sort of game optimized at this point that the chronic disease management is absolutely sort of not in the radar screen. It's all about expensive cancer chemotherapy and cardiac surgery and TAVIs and TAVRs and all that kind of procedure, which is all great advances. But the question is, while those advances are occurring, why are we not talking about the bigger problem that we have? I'll come to that sort of again in a second. So the game theory is sort of optimized for sort of the big players, and in the middle, at least in my opinion, we're sort of completely missing the picture. Okay, so that was a little bit of a focus on the healthcare system. Now, what about sort of us as an individual, as clinicians, as doctors and nurses? I think we sort of have some problems to deal with personally also, and not just sort of focus on externally and blame the external audiences. So 2-3 years ago, I sort of published this a viewpoint that polypharmacy is not a problem, it's a progress. And the whole idea that we were trying to say here was that, look, I mean, we're living in a society with polymorbidity. People have 2 or 3 different diseases. And yes, it complicates, but appropriate polypharmacy is a blessing that we have all of these drugs and that we should be treating these patients aggressively. Now, again, over-the-counter and multivitamins and all that kind of stuff that people take, I don't know what they do. But in terms of appropriate polypharmacy, there is such a negative connotation to polypharmacy that I think we need to sort of change the narrative. I had no idea what I was walking into. I just sort of published this just like a medical editorial. So somebody tweeted it out and just started sort of saying all of these things that, you don't care about patients and you don't care about, I don't know, dizziness and blood pressure. I'm like, no, I care about all that. But the bottom line is we got to treat these diseases. So, and again, this is earlier part of my Twitter days. I don't engage in any debate on Twitter anymore. I just sort of put cats pictures up there. But at that point, I sort of thought this is a healthy discussion and I'll discuss. And then they started getting personal that, oh, you're just a shill for pharmaceutical companies. And of course, you're conflicted. So of course, you're going to push drug. I'm like, I'm saying just these are chronic diseases. We need to like control blood pressure. So I think this sort of is a really a fundamental issue, sort of deeply ingrained in us and sort of this Hippocratic oath about first do no harm. And it's really problematic notion that first do no harm, because the only way to do no harm is to do absolutely nothing, in which case, ironically, we will do a ton of harm, right? Because there is nothing we can do in medicine that does not have a potential of doing some harm. I mean, you cannot give aspirin or acetaminophen without doing some harm either. And I think what the idea here was that first, do no deliberate harm. So don't put a stent in if you have a 20% atherosclerotic lesion. First, do no deliberate harm, and not doing what needs to be done is doing harm. This is a fundamental thing that the errors of commission are way overvalued by physicians and nurses than errors of commission. So if you do something and there is a side effect, we don't want to do it. But if you don't do something, then it's God's will. Right, so we don't. So when we don't treat a CKD patient or a heart failure patient appropriately, and they go on a transplant list or they go on dialysis, we don't say that that is because in the primary care and general cardiology and specialty, we never treated the patient appropriately for the past 7 years. We just say, well, that's the natural history of the disease. But again, if you look at the treatment of chronic diseases in the community setting, maybe we need to sort of think it through a little bit. Then this then leads me to sort of a third question, and that is sort of what is our fundamental role as scientists, and should we be sort of thinking about trying to get to the truth? This gets complicated really fast, really fast. So I don't exactly know what truth is. So so one is sort of the physical truth. That's the one that nobody would argue, right? So speed of light, you can go, oh, this is the speed of light. I mean, that's the truth. Except that the speed of light is that speed of light depending on whatever the dark matter and the dark energy is, and we don't understand those constants. And if those constants were to change, the speed of light will change. So the truth is a little bit of a relative. Then is the canonical truth, right? You shouldn't kill anyone, right? I mean, that's a canonical truth. But animals, that's okay. You can kill them and eat them, right? So there's a degree of relativity in canonical truth as well. And then the third is simply taste truth, right? I mean, I like red color and Peter like blue color. I mean, there's no sort of external validation, but that is our truth. So once you start sort of thinking about, the truth, it becomes sort of really tricky issue as to what we're trying to do. So if you think about how we do clinical trials, I mean, the whole enterprise in my mind is entirely absurd. So what we do is that we sit and we say that we're going to test SGLT2 inhibitors in MI patients. So we do power calculations. And the way we do power calculations is we say that I'm going to hypothesize that there's a 25% relative risk reduction with a base placebo arm of this, and so many events are needed to prove the hypothesis. The fundamental thing that I am hypothesizing, a 25% relative risk reduction, is completely made up. It's entirely made up. There is, I mean, 25% relative risk reduction, and that's what we're going to do in a clinical trial. And then we say a clinical trial is positive or negative for the same thing. So like, for instance, Victoria trial had a p-value of 0.03 with a 10% relative risk reduction, and it's a positive trial. And then under the trial that did not power enough and had a 10% relative risk reduction, it's a negative trial. I mean, we are in the business of testing our hypothesis. We are not in the business of testing the truth. And the problem when we do that, when we test hypothesis and we don't test the truth, is that then translates into guidelines, and appropriate therapies are not given to the patient. Why don't we live in the world where we basically have some sort of a Bayesian idea that this is your point estimate, this is what you found, this is what the confidence interval is, and whether you should give the therapy to the patient or not? In other words, should the scientific structure be developed to answer the scientist hypothesis, or what is the best thing we can do for the patient? One is a frequentist approach, and the other is a Bayesian approach, and we are completely living in a frequentist world. That makes totally no sense about this. So at the end of the day, what do you do? I mean, you got to sort of make a decision for the patient. So I don't know whether there is there are a couple of writers after which I think we should have stopped writing books because nobody can write anything better. And one of them is Dostoevsky. And in Brothers Karamazov, it says that if it takes the suffering of a single child to know the truth is not worth knowing. And I think that medicine should be much more about kindness and about sort of patient focused. As opposed to the structures that we have created, which is complete financialization of the medicine ecosystem, and the scientific structure right now is not necessarily geared towards that as well. Let me, in the interest of time, not talk about sort of individual responsibility, and let me sort of get to this. So one question is, so now you're in a healthcare system, you're any chair you're in, you're the front receptionist, you're a dietitian, you're a surgeon, whatever, doesn't matter what chair you occupy, but you're part of the healthcare system. The question is, what is sort of the orientation you have? Well, you can have a very helpful orientation that I want to be a helper. You can have a orientation that I want to fix the system, or you can have a orientation of serving, right? So when you help someone, there's already sort of a hierarchy, right? You cannot help unless and until somebody is weak, right? So there's a weakness and you're trying to help. If you're trying to fix something, well, you're not going to fix something which is not broken. So if you're fixing something, then your mindset is that something is broken that I'm fixing. But when you serve, then you sort of accept the reality and you sort of serve overall. So I like this quote that fixing and helping create a distance between people and experience of difference, whereas we cannot serve from a distance. We can only serve to which we are profoundly connected. And I think that is sort of the calling, because for chronic disease management, when we talk about multi-morbidity chronic diseases, that sometimes we sort of shy away, and the patient is painful and the family member is painful and I don't have time, and all that kind of stuff that we do, and we focus on procedures and imaging and all that kind of stuff, all of which is good. Please don't take me wrong. I mean, that's awesome. But unless and until we develop sort of this attitude of serving, it's really sort of important. The other sort of concept is this sweet spots in our life, and that sort of translates into institution. And by the way, I will fold all this into a message just in case if you're wondering, like, where is this whole thing going? Give me 5 more minutes. So the other thing is the issue of sweet spot, right? So as we grow older, we grow wiser, but as we grow older, our energy level goes down. So you sort of come to some point at a point where you are sort of at maximum energy for the maximum wisdom that you have. And going forward, you might be more wise, but you clearly have less energy. And going back, you're like sort of my children with a lot of energy, but not a whole lot of wisdom. So this is sort of the sweet spot, right? So what is an organizational or an institutional sweet point? Well, that is where the organization has sort of optimized the sweet spot for its employees. So how do we create a healthcare system where we are optimizing the sweet spot, but not only optimizing the sweet spot, but increasing the bandwidth, so become wise sooner and become wise with the full energy for a longer time frame? That's the challenge for the healthcare system leadership. And in the era of complete financialization of medicine, nobody is sort of thinking in those terms per se. So just sort of keep that idea in the mind. So wrapping up my presentation, there's a lot of focus on patient centricity, appropriately so, right? We live sort of in a consumerism in medicine era. People are going to Google, they're doing sort of their searches or whatever. So there's a lot of focus on patient centricity. If you ask patients and you do the interview with the patient and ask them, what is the number one thing they want? No matter what the disease state is, the number one thing that the patients want is to have nothing to do with us. They don't want to come to the clinic. They don't want to come to the hospital. They don't want to have anything to do with us. They want minimal possible contact with us. And when I go to the meetings about patient centricity, and again, I really don't mean to sound negative, TAVR is great. super, MitraClip, great. But again, not at the expense of sort of not doing these basic things. So when we talk about patient centricity, it's about parking, it's about the quality of the food, it's about sort of, whether you picked up the phone in, 5 rings versus 3 rings. All of that are great things. But we are sort of completely missing the picture that the number one thing we owe to our patient is to have least amount of contact with us. And the only way that will happen is by treating chronic diseases. Aggressively to target treating multimorbidity. Now, yes, we could live in an even better world where everybody would bike to work and primordial prevention and everybody would be thin and we won't have multimorbidity. That's great. But till we get to that point, at least treating these primary care diseases and not wait for people to develop significant diseases. The second thing is coming back to what is the role of the system, right? So this afternoon, after this talk, I'll take a flight from Air Canada or United or something like that. I'm going to Chicago. Anything that happens in my flight is delayed, my luggage is lost, the person serving me Coke has a bad attitude, whatever it is, I'm not going to blame that person. I'm just going to say, Air Canada really sucks, right? I want to be in Delta. But in healthcare, we don't have that mindset, right? It is for a person to come in with the same complaint today can get a completely different care if they see a primary care physician, a general cardiologist, a cardiac surgeon, an interventional cardiologist can go in sort of various different directions. And all of these trends that I am showing you, there is not a single healthcare system that is taking on the responsibility. I mean, if you walk into, I don't know, what's your big store like Nordstrom or whatever, at some point, your experience is dependent by the system. System takes on the responsibility. But in healthcare, we take no responsibility of the patient's well-being, except when we are measured like door to balloon time or something like that. But these chronic diseases, we take no responsibility. So we need to sort of create a system whereby the focus on implementation, the focus on system-wide population management at some point will have to become a reality. And this is especially important in the era of incredibly expensive medicines that we are going into with CRISPR therapy and gene therapy and who should get it and who should not get it and what is the appropriate use of these drugs will also sort of somehow force. But chronic disease management and health system taking on the responsibility, saying that, it is the responsibility of University of XYZ that anybody that comes in here, we have a plan of how we will take care of these diseases. Artificial intelligence obviously is going to sort of change a lot of the things. We had a bunch of discussions, so all sorts of sensors and continuous 24-hour monitoring that is coming down the pike. Virtual care is obviously coming. There are apps where you're talking on the phone all the time. So the app has an idea about your intonation and all kind of voice. And now you have a little bit of pulmonary congestion. So you have a little bit of shorter breath. You're not even close to being admitted, but the app will pick up changes in your voice and will sort of detect that there is early congestion coming. All those kind of things. I mean, there are bathroom sort of commode seats coming in where you sit in the morning and relieve yourself. So your weight is automatically recorded and it is sent. But it's not only the weight. It has impedance optival technology in it. So it can also just give you on a day-to-day, just going to the bathroom, all of the data is passively collected and coming. So all of these things are coming that will significantly change the way we are doing. We were having some sort of interesting discussions last night, and that is, singularities do occur. And when singularities occur, you sort of go on a completely different path. So sort of the first singularities was when sort of we went from archaebacterium to eukaryotic cells, right? Complete different trajectory of the animal kingdom. The second was chlorophyll. So chlorophyll and the animal kingdom and the plant kingdom that has occurred. So we don't know about this human versus computer and AI and which direction all of this will continue to evolve. Again, we were sort of talking about this last night, that the notion of life is metabolism and reproduction, and computers obviously have metabolism, which is electric, and their ability to self-perpetuate is almost there. Consciousness was missing, but it's coming with AI. So in a way, we are sort of meat-based computers with carbon-based intelligence, and computers are sort of silicon-based intelligence. But these things are starting to get sort of pretty merged pretty fast. All I can say is that even at my age, I can predict that in my lifetime, a lot of the doctor's job will go to not doctors, and a lot of the non-doctor's job will just basically go to robots and computers, especially with sort of the humanoid robots that are coming down the pike. All the recognition technologies, whether it is echocardiography or dermatology or pathology, I don't see how human beings will be doing those things in the future as opposed to the computer. And then this whole sort of interface of human computer together will be, at least to me, a very interesting time. And I hope I live long enough to see some of that. Okay, so this is my last slide. So how am I sort of seeing this big picture of chronic cardiovascular disease management, where I don't see my health system administrators interested in, I don't see the cardiology leadership interested in, and in the meantime, we have all of these people walking around with uncontrolled hypertension, uncontrolled diabetes, uncontrolled obesity, and uncontrolled CKD, and that's just the way it is. So yes, it will be good to wait for Godot, and at one time people will be bicycling all the time. But what can we do till then? So these are sort of 10 tips that I will leave. This part is a little bit too much standing on my soapbox. So this is for the trainees, younger people, some advice. So one is that we really need to realize human suffering. I mean, that is critical. So one thing I do in rounds is that, you're rounding with these students and residents, and they're all like, young and in good shape. And I'm like the only one who's out of shape. And we just sort of, the cardiology floor is on the 4th floor. So we walk up 4 flights of stairs. And then you ask them one simple question: how do you feel? And then tell them that your patient feels like that going to the bathroom or going to the kitchen on flat surface. That's what a heart failure patient feels. When we are in a rush and we tend to ignore and not treat. Now, again, when I say we, tertiary care centers traditionally do much better. I'm just talking about population management overall as a community. When we don't take care of these things, in a way, the human suffering that we could have relieved, we end up playing a little bit of a part in that we fail in avoiding that human suffering. So all considerations true, we have to be very cognizant, at least to think about human suffering all the time. The second is sort of accept less than ideal. Some progress is better than nothing. So any one of us that have been in any leadership role, that, you go there with your sort of, chest all thing because you got like, something got done, and then you go to the meeting and like the faculty is like throwing darts because it's not perfect. And, why didn't you get this done? And that I'm like, well, but I got this done. So again, incremental progress and at least making few steps, even this afternoon, in your practice is great. This issue is really difficult, the sensitivity versus specificity of decision making. So I can give you my answer, but you need to at least think about it consciously of what your decision making process is. So assuming safety is the same, medicine is not a perfect science. So the question is, I have 2 options. Again, assuming that safety is not a concern. I can either treat more patients knowing that a few people will not get benefit, but I want to get everybody who could potentially get benefit from the therapy, get the therapy. Because remember, we are not in the precision medicine era. I don't know who will and who will not benefit. Or you can say that in my ethical standard, it is unethical for anybody to get a treatment who's not going to get benefit. So I'm going to give it to only people that I'm definitely certain will benefit. And in doing so, some people who could have benefited may not get the therapy. Our guidelines structure is predominated by the second phenotype. They will give conservative recommendations so that anybody who do not benefit don't get the therapy, even at the cost of people who could have benefited, they don't get the therapy. And my at least mindset is that I would over-treat to make sure everybody who could benefit, and not miss some people. You will decide sort of for yourself. I think being of service is probably a little bit of a better idea than fixing something or helping something. Remember that a lot of your truths are basically only taste truths. There's no external validation to your truth. And I think that kindness is more important than truth. A lot of change is coming with this whole AI and computer. So just brace yourself and be ready for the discomfort. We need to own our own institutional Molochs. It's easy to say that the CEO is doing this and the chief of cardiology is doing that and the chief of this is doing that and the chief, but I mean, they are all the product of us cumulatively. And I think that changing the incentive structures through which we operate, at one level for professional societies and who you vote and all that kind of stuff is sort of external, but I think there is some of that we can do internally as institution as well. This obviously is not for you, for the Canadian colleagues, but the US has to move to a single payer healthcare system. So I won't touch about that. The system has to be responsible for care. System has to be responsible. We cannot, as a system, continue to hide behind individual doctors and nurses and blame individual doctors and nurses. And then lastly, boy, we don't know anything what we're talking about. So some degree of humility would go a long way. So Camus, got the Nobel Prize on Stranger and got a lot of notoriety for the myth of Sisyphus. But if some of you have not read this, the book that probably, other than Brothers Karamazov, has guided my sort of way of thinking the most is The Fall. And I would highly recommend. Very easy to read, short book. You might want to read Fall. So thank you very much. I just thought I'll do a little bit of an experiment and go a little bit off the hook and talk a little bit more philosophy than science. And I appreciate being invited. Thank you.
Thank you very much, Javed. That was outstanding and such a wonderful reflection for us in terms of where we are and where we think we need to go. I'll just open it up for questions. If there are folks in the room, if they can come to the mic, I'm full so the people online can hear. And I'm just going to scan here just to see if there are. All right. Sorry about that. So the mic is on now. Maybe I'll take the opportunity to ask ask a question. I was really very intrigued by how you wove through the talk the sense of chronic disease management and how important chronic disease management is. I really liked how you did that. And I'd love to get your thoughts. One of the things that I see as a heart failure doctor is the fragmentation of care for our patients, because our patients don't just have heart failure, right? 30% of them have diabetes, atrial fibrillation, chronic kidney disease. And so we see patients in our system that are seeing multiple specialists for each individual problem, with very little ownership or approach to the holistic patient. And this problem is compounded further by a real lack in our region for primary care. And so the quarterback, that sort of primary care physician quarterback for many of our patients is gone. And I think personally that this does contribute to some of the gap that you talked about at the start of your discussion. So I guess my question is twofold. First, what are your thoughts on fragmentation of chronic care as we supra-specialize our patient experience? And two, how do you recommend we better integrate the care of a patient and make it more, you talked about patient-centric, but truly patient-centric to improve our outcomes?
So a couple of thoughts. As I've sort of grown older, I'm sort of getting less and less excited about the word advocacy. It just doesn't work. So I think we need to sort of create systems where the healthcare system actually sees tangible benefits. So it's not appealing to do the right thing, but there are tangible benefits. If you are putting in more money and you're getting more out of putting in more money, okay, fine, then maybe it's worth it. The healthcare system that we have created with the fragmentation that you're talking about, actually putting in more money is resulting in even worse care, right? So you have all these specialists. I mean, look at it from a patient perspective. They see a nephrologist and an endocrinologist and a cardiologist and a primary care, and one office this and one office that, and then you do this and you do that. Why are we doing any of this, right? I mean, can you potentially live in a healthcare system? So again, first of all, just because what I'm about to describe may happen 20 years from now doesn't mean we don't improve our clinic this afternoon. If we can just worry about sort of the human suffering and just do whatever we can today with incremental benefit, that's great. But why can't we imagine a healthcare system where the nephrology, the endocrinology, the cardiology, the primary care leadership sits together? You have everybody agrees on the same protocol. You don't have every professional society have their own guideline. You have this sort of the multi-morbidity management guidelines, and majority of which can be managed by nurse practitioners and can be managed virtually. You don't need doctors and you don't need in-person visits. All the tools for labs that we commonly need, there are either available or there are prototypes being developed that you can do it at home. There is actually a company now, which is already, it is happening today, that you mail in an echo probe, then the person logs in on the video tells you where to put the probe, so you are doing your own echo on the TV, and then just like, I was in whatever your bathroom, it turns like red or green whether somebody's in or not. It actually turns when you have the right image, then it says, yeah, just hold there, don't move. And then you do your own echo, you pack the box, you mail it back, and everything is sent electronically, and your echo is done at home, right? So I think that if we want to do it, all of this fragmentation can go away at least 70%. At least 70%. And then the more sicker patients and more complicated patients, they can come in and they can see the specialist. But I think the way we have created the current infrastructure is, again, I'll go back to it. It's entirely related to the financialization of medicine, and those pressures are driving the structures that we have created.
I can, sort of stand here an hour to ask you amazing question. What a, fantastic mind expanding lecture, in terms of really, I think it's a moment of singularity that we, have here. So, it's kind of a follow up from the discussion yesterday, create, sort of some of the solutions, to the major problems that we have. This is kind of a really follows up on that. And it reminds me of two things. One is, Victor Zhao actually, had this Lancet lecture that was published in the Lancet talking about, sort of the future of, physician's role. And, so in addition, kind of, sort of building the knowledge on scientific foundations as used to be. And, but then the physician really needs to be kind of the patient's, I guess, health coordinator in a way in which is really actually going to be built on compassion, beyond the science. But then additional part is actually the physician needs to actually now go beyond just that single patient to actually begin kind of be the nexus with the health system, and which is not something that I think physician, traditional education actually focuses on, but says that this is really actually important. And reflecting on the comments you made earlier and things like that, as healthcare has progressed. And in fact, I have to say that we as physicians, we customize the system for the system's convenience rather than the patient's, so that's why there's fragmentation. That's why we run our clinics based on our schedule, right? Rather than what the patient 100%. Needs, right? We actually organize our health, in terms of efficiency for the system. And so, for example, we have a large grant, which is on brain and heart interconnection. The whole idea is actually for the morbid patient that we actually bring, so the system around the patient, and also particularly, taking the mind component into front and center in terms of motivation, in terms of, sort of a patient's engagement and all those aspects. So I was just trying to figure out, maybe it is time for us to really kind of relook at how we, sort of carry out the health system, right? In which we truly, bring the patient into the center, but at the same time, we begin to actually reevaluate, the wellness of the entire process rather than kind of these one single fragmented metrics at a time. Sort of just.
No, completely agree. I mean, this will be sort of major disruption, but it's not something we cannot do. The issue is the willingness and the fortitude of dealing with the disruption, right? I mean, it's completely different way of thinking. And not only for the cost reasons, but I think we really owe it to our patients. I mean, if you look at the AHA statistical report for the past 10 years, the fractions change, but nothing has changed.
If I may, there's a question online, a great question. It addresses number 9 there on your list. Please provide specific ways that we can increase or create system responsibility.
Yeah, so I mean, the question here is, how do you go? So I have now spent considerable amount of my time working very closely with the C-suite. And all of these sort of, notions that, they only care about money and they're on this. I mean, that's absolutely not true. Absolutely not true. The healthcare system leadership are like people like you and me, and they're just trying to sort of do the right thing. But remember that they have their own incentive structure that has been given by, the government or the board or whatever that they are sort of responding to as well. So I don't know how far up the chain it goes, whether it comes from the government or the payers or the insurance companies or whatever. But look, when I was a cardiology fellow, we gave streptokinase. The TPA trial came when I was a fellow. There was no such thing as primary angioplasty all the time. And the streptokinase was given sometimes early, sometimes late, sometimes the patient came whenever they came or whatever. And now, in the entire United States, you come in with a STEMI, you're getting an angioplasty in 90 minutes. And if you're in a rural setting, the ambulance setup is made, you know which hospital to go, everything is done. So if you wanted to bring a mega change, now go back to 1995 and imagine this system and the amount of barriers that you can think about. 24/7 cath lab open, doctors available, doctors cannot live beyond certain mileage. You're going to mandate that on the doctor, available middle of the night. How can this occur in rural? And we did it, right? In 20 years. What we're talking about here is much less onerous than having STEMI 24/7 all across US within 90 minutes. So I think it's only a matter of incentive. And right now, the healthcare system is just not incentivized. Now, whether that incentivization comes from payers or government or what, that I don't know. It's only an issue of incentivizing. It goes back to my concept of Moloch that I mentioned, is that if something that all of us agree should be done, and all of us agree can be done, and it's not done, why is that? And that's entirely related to incentive structures.
Thank you so much. Just in the event of time, maybe we'll close out. And again, Dr. Butler, I want to thank you. You have lit a fire under all of us today. I think you've given us a lot to think about and reflect on. So thank you very much. We really enjoyed your presentation.
Thank you.